system, which has officially launched in the UK recently. So I have developed subspecialty interest in hyperpigmentation through master's degree I did at the Manchester University, and I've also done various observerships in America, Singapore, and South Korea. And I have been running the first and only hyperpigmentation service in the NHS hospital for a few years before I set up my own private practice in High Street medical area. And quite often I use combination of cosmetic, medical, and laser treatments when I manage hyperpigmentation. So today's main focus is on the new Cyspera intensive system, but I also want to go through the process of melanin production, how you can assess the patient to select the suitable patient for Cyspera, the current gold standard treatment for hyperpigmentation, which is currently hydroquinone, and how Cyspera can be an alternative safe option for the management of hyperpigmentation. So to understand how melanin is produced in our skin, we need to know about the skin anatomy. So the outermost layer of our skin is epidermis, which is mainly comprised of keratinocytes and melanocytes, where melanin is actually produced. And below epidermis is dermis, where it is highly vascularized and it contains collagen and elastin fibers, as well as many cells, including fibroblasts, T cells, macrophages, mast cells, and neutrophils. And dermis also contains hair follicles and sweat glands. And this diagram shows different cells making each layer of the skin, as mentioned earlier. So as you can see, the melanocytes are located at the basal layer, so at the bottom of the epidermis, at the junction between epidermis and dermis. And melanocytes produce melanin. So melanin is actually produced within an organelle called melanosome, which is shown as the yellow small circle in this diagram. And these melanosomes travel along the dendrites, which are finger-like projections, to release melanin to nearby keratinocytes. And each of these melanocytes is connected to 30 to 40 keratinocytes via the dendrites, and it passes on the melanin. So melanin is produced within melanosome using amino acid tyrosine as the major substrate. So tyrosine is converted to dopa followed by dopaquinone via the action of this enzyme called tyrosinase. And many skin lightening ingredients such as hydroquinone, arbutin, and tretinoin inhibit the tyrosinase and are blocking this first step of melanin production. Dopaquinone is then converted to either eumelanin, which gives the black-brown color, or pheomelanin, which gives the red-yellow color. And with the action of glutathione or cysteine, the pathway shifts from the eumelanin to pheomelanin production, giving the lighter skin color. And you need to remember that hyperpigmentation is a broad terminology to describe darkening of an area of the skin or nail caused by the increased melanin, and it's not a diagnosis. And there can be many causes and differential diagnoses which can cause hyperpigmentation. And one of the most common hyperpigmentary conditions you may see in your clinic is melasma, which is a chronic relapsing disorder associated with hormones, UV, and visible light, and appearing as symmetrical patch, as you can see on this diagram. However, there are many other hyperpigmentary conditions, such as post-inflammatory hyperpigmentation, which is often induced by some sort of inflammatory process, whether it's endogenous or exogenous. And on this photograph, you can see the PIH caused by the chemical peel and microdermabrasion. And other differential diagnoses include freckles, which occurs mainly as a child in paler skin, in Caucasian skin. And then also you can get the lentiginous, which occurs with the sun exposure or aging process in Caucasian or East Asian skin. And then horis nevus, which is common in East Asian,